Hey, today's webinar is brought to you by Benchmark Human Services, who is an MHPA Bronze partner and longtime supporter of MHPA and our health plan members. We thank them for organizing today's presentation, advancing crisis care and enhancing support systems to improve member outcomes. I'm excited to introduce the Benchmark team, and they are Doug Beebe, CEO, Brian Gill, Vice President of Behavioral Health and Crisis Services, and Charles Bird, Arkansas State Director. And with that, I'm excited to turn things over to our presenters.
Well, hello, everybody. Thank you for joining us. I'd like to take a little time to introduce Benchmark, who we are, and what we're bringing to the table and what kind of led us to our topic of today. So we were founded in 1960, but I think really the hallmark moment for us was in 2007. The board of directors decided they needed to greatly expand the mission and reach of our team, which at that point was in 3 states. So they created 3 entities out of the original not-for-profit. One is a not-for-profit is still in operation. The second was Benchmark to kind of be a growth and entrepreneurial engine. And the third was a foundation that owns 60% of Benchmark. So that foundation receives 60% of our revenue, leases some buildings to us, and they give out annually $5 million to $8 million in grants to expand community accessibility for people with disabilities throughout Northeast Indiana and sometimes some of our other states. And the cool thing about it is that we all retain a shared mission. And really the keys to that mission are we look first at the potential of everybody we serve, and no matter what program we're in, we really want to get away from diagnosing what's wrong with people and look at what their potential is, what their dreams are, work on that and help elevate them so they get more independence, and that leads to more inclusion in the community. And it's been pretty successful for us. We've had quite a bit of growth. Now, this next slide will show you we've gone from 3 states to this current array. As we've grown lately, in particular, a lot of our programs have been specific to a very individualized need in the state. So we don't use a one-size-fits-all approach to our programs. We do have a heavy background in residential and some other services. But I think really what's important is our geographic reach expanded, so did our programs. And you can see that we really did start with employment and residential services. And I think what took us on the path we're on now was the Department of Justice came to Indiana and started forcing the closure of the last IDD state hospitals. And because of that, a whole new service arrays had to be developed within the state of Indiana. We were fortunate to be able to help develop specialized programs for people with extensive medical needs, people with extensive behavioral support needs, and moving those people in the community and doing those community transitions for people who have been institutionalized for a long time began to show some of the cracks in the system that weren't ready to receive that population. So that eventually led us to doing crisis services for the IDD population in Indiana in 2007. And then it led us to doing IDD and then behavioral services and crisis in Georgia, which kind of developed a pathway that we're on for today's presentation. And as we did this and we developed our expertise around those populations, we began to develop what we call customized solutions. And we started working with states and sometimes MCOs or managed care entities to work on a specific population that was causing some real problems. And I think where it really became evident to us as we serve more and more people with complex needs in the community, we kept seeing the theme develop across every state that we entered or every state we worked with. And that was there's this population of people that are very difficult to serve. And the way we talk about how difficult they are to serve is they continue to lose providers. They flip-flop through providers. They get stuck in an emergency room. They go in for an inpatient hospitalization, maybe for behavioral health meds, and they're in the hospital for 300 days. Or they're continue to have, as we call, engagements with law enforcement, which is jeopardizing their placement. And the people leading those lives are having truly, really terrible lives, not well integrated in the community, not getting any pleasure or growth out of their life. And so we developed this idea that my colleague Brian is going to expand upon a little bit more.
All right, thank you very much, Doug.
I want to thank everyone for attending today. And just again, if you have any questions, you're welcome to put them in the chat as we go through our presentation today, and be happy to answer them at the end. As Doug was saying, is that through our experience in Indiana, providing services to individuals with intellectual development disabilities and also co-occurring or dual diagnosed behavioral health disorders, we identified the fact that there were gaps in the system and the way the system worked with those individuals, and really that fact that there wasn't a good fit for them. One, either the services they were receiving in the community, or more specifically from a crisis standpoint, that they would often cycle through. And we'll talk more about that in a moment in regards to how the access model came into being. And so that experience in Indiana, it expanded in Georgia, where we developed and we provide mobile crisis services starting in 2011. That later ended up being a blended mobile crisis service for both behavioral health and individuals with IDD. And we also established 9 different IDD crisis respite homes in the state of Georgia, 7 serving adults, 2 serving youth, that really take those individuals that would normally be kind of stuck in an emergency department, be labeled as unable to serve in the community, maybe have contacted law enforcement or other EMS first responders, and really not be able to be supported or served properly in their living environment, whether that be their own home or in an institutional or a resident home in the community. And so in Georgia, we take those individuals into those crisis respite services for a period of time, stabilize them, and have them return back to the community to be served. The model in Georgia is well supported and has been doing very well for itself, but we really wanted to be able to take the experience that we've learned from Indiana and Georgia, the knowledge that we have in working with this population, and really be able to share it with other providers and across the United States, really to be able to help more people. Practically, as an organization, we don't have the capacity to serve, all individuals in all 50 states. And so the idea is we also wanted to be respectful and knowledge of the culture, the existing rules and regulations that there are in each state, and also the existing providers that have that local knowledge that have been in place for a long time. So the idea of being able to come in as through the Access program is being, as it says, a system-focused partner, that we want to work with the individual organizations that are struggling with the population that we're talking about. As a quick aside, back in 2013, Milliman did a study of individuals that are on Medicaid that have a behavioral health condition. And as I'm sure you're all aware, is that individuals, if they have a behavioral health and medical condition or another co-occurring disorder, your PMPM spend is 340% more than if they don't have a behavioral health condition. So this is obviously a population that you're already very conscious of and that you're working very hard to serve. And it's that population with behavioral health and co-occurring IDD diagnosis that and our expertise that we want to directly serve. One, to keep them in the community, give them better quality of life, but also address the issues and concerns that are driving the repeated failure of placement in the community, unnecessary use of emergency department services, or long-term placement out of the community, whether it be in a psychiatric hospital or residential treatment. And so our work is that we work closely with the providers and also with the managed care organization involved, who usually identify the individual that needs to be served. We want to be able to increase engagement with the individual client and also any family members and agencies working with them. We want to break that crisis cycle, and I'll talk more about that in a moment, and also eliminate the barriers of service, which are often there are service gaps between behavioral health and IDD, depending upon what state you're in, what agencies you're working with, and also that system fragmentation that occurs quite frequently in serving people that have dual diagnoses. Give me one second. So as you can see, the typical trajectory for someone with a dual diagnosis is the fact that they are your highest spend. As I usually refer to it, this is your 5% of your service population is probably driving 50% of your PMPM cost on a regular basis. And so these are the individuals that we want to be able to support and serve in the community. And so we want to break that cycle of crisis, try to avoid having them go to the emergency department or psychiatric hospitalization unnecessarily,
make sure the fact that we can maintain and support the individual and the providing agency that's working with them to maintain them in the community, avoid unnecessary incarceration or engagement with law enforcement in the community, and also any long-term institutionalization. So as you can see that the model that we've developed in working closely with Station MD as a telehealth, behavioral health, and primary care partner, where we can actually provide urgent medical care and routine medical services and psychiatric consultation via telehealth to the individual, which is often a barrier for this population, to help stabilize them from a psychopharmacology standpoint, but also deliver our services where we are both there in person, side by side, with the providing agency, with the family, with the client, and we're also providing consultation and support and training to the provider staff. And we've had great success in implementing this model in Arkansas. And so I will turn it over now to my colleague, Charles Bird, who can talk to you more about the work we did in Arkansas.
Thank you, Brian. And thank you everyone for being here. As Brian mentioned, please do not hesitate to shoot a question in the chat if needed. If I'm talking about anything that doesn't make sense, or if you need any clarification, please let us know. When we joined and started services in the state of Arkansas, a lot of the issues Brian was discussing. We had individuals there with very complex needs. They weren't sure what to do with them. They ended up having no placements for these folks going out of state, and very, very costly. And so they brought us in, Managed Care was able to bring us in using some community investment funds to launch our capacity building program. This started with a thorough assessment with a few targeted, waivered, and home and community-based service providers, as well as some mental health providers across the state, looking at what were their needs and what did they want to see in terms of the gaps we could fill and how we could provide support. And when we started, it was the two populations they talked about: individuals with intellectual and developmental disabilities and people with very complex mental health needs. Now, everyone initially asked for, one of our main things we're going to need is crisis training, crisis support. We're having a lot of difficulty, a lot of crisis situations. We're not sure how to handle it. And that was the main focus that everyone wanted us to look at. And so with this, we went in, we were actually able to do that comprehensive systems assessment and actually kind of reframe that in terms of, yeah, you guys do need some help in terms of how to manage these crisis situations, but also these providers. How do we make it so we're not repeating and having the same crisis situations over and over again? How do we go upstream and prevent those crises from happening? This included, looking at how they onboarded individuals into their agencies, how they trained their staff, what sort of person-centered supports they were providing there, and what kind of programming they were offering to all of their consumers. Looking at all of those things, we were able to make some really targeted and tremendous impacts, not only on those agencies, but on a lot of the individuals that we had referred. With this, we developed a really great foothold in terms of our capacity building and what we were able to do in that case. This transition, when our capacity building contract ended up, they wanted to keep us around. They said, you know what you guys are doing here is really, really wonderful. We don't necessarily know if we want to fund this through community investment dollars. Again, how do we look at getting you guys set up as an actual provider in the state that is able to provide this as an actual Medicaid service? And so with this has launched our access model in the state, which allowed us to actually have a little bit more ownership and direct care in working with the individuals we were working with. So now what we're able to do is the agencies are able to identify individuals with very complex needs. And one of the big beauties of Benchmark, we work with just about anybody. We are not one of the providers that says, they may or may not be in our threshold. We're generally always going to find a way of how we can work with the individuals we serve. And so with that, we were able to identify some of those individuals, as Brian said, the 5% that are driving the high costs, and we're able to give them some of the programming that those individuals would not have access to on their own. That would include access to a board certified behavior analyst, to write behavioral program, to do behavioral assessment. Very difficult to get therapists that are willing to work with individuals with intellectual and developmental disabilities. We provide that. We provide a lot of more community-based mental health services and a lot of other pieces there that they were not able to access prior to Benchmark's involvement. And so with this, we're not only working with that individual, we also embed ourselves within that agency, and we help to build their capacity to not only work with the individuals that we get referred for, but the next individuals that come through their door who have those complex needs. So now we have providers who had a fairly low threshold in terms of tolerance for difficult members, now able to serve individuals with much more complex needs, giving community placement to individuals that would otherwise be institutionalized, cutting down on costs, and a lot of the outcomes I'll talk about in just a moment. So with our program now, we get a referral from the managed care organization. We wrap a tremendous amount of services around that individual in a very targeted fashion. We provide 24-hour crisis support. We help to develop programming for those individuals. And then we work on how do we exit out of this so it's a temporary service and we can use the natural supports in the state to maintain these individuals. We do a warm handoff with the managed care organization, with the providers we work with. We develop the plans, we train the staff, and we really set up that system for that individual to be successful. Additionally, our 24/7 crisis support has been a real tremendous impact in the state in terms of a lot of individuals that would filter through emergency departments, go to acute settings, end up in ICFs or human development centers. We're able to keep those individuals in their homes, in the community, and be able to disrupt that cycle of always having to go in. That's not only really great in terms of person-centered care, helping those individuals to achieving a great level of community integration, but also substantially cuts down on costs in terms of ambulance rides, workman's comps, people going in, having to pay for emergency department visits, everything like that. Okay. So with this, we're able to address social determinants of health, help out with those members, help out with those individuals, increasing the provider's capacity, and once again, cutting down on costs and saving a great deal of money in the process of this. So in terms of looking at our capacity building, this is just a snapshot of several of the individuals that we worked with. And this is essentially what we are monitoring and what we are always trying to do for the folks that we are referred. They come in with a certain number of incidents. They come in with a certain number of police contacts, hospitalizations, anything there. Our goal is to reduce that number. And so you can see here through our process of clinical interventions, doing consultation, training staff, doing some real-time coaching, we're able to actually have a very tremendous impact. A quick segue, our training is a little bit different. We are more than happy to do Zoom and classroom model trainings, but we are not an ivory tower provider. We show up. If they have an individual that's engaging in very significant crisis behavior, we don't train the staff in a classroom. We go out and we train that in real time. We work with them in those moments, provide that coaching, and actually help to model and display and coach on how to do the things that we need them to do to be effective. And so as you can see, we've had a lot of individuals here. We're able to have a pretty significant reduction with a lot of these individuals in terms of their rate of incidents, hospitalizations, acute stays, everything like that. The beauty of this with the capacity building aspect of really working with that system to increase their ability, most of these folks had long-lasting, sustainable changes. They're still serving the individuals even after we removed ourselves from that and discharged those individuals. So it's a very good long-lasting change. In our access model, we've seen a tremendous influx in terms of foster care individuals, adolescents, teenagers, no place to go, where we've had monthly hospitalizations. We've been able to take a lot of those folks and get those hospitalizations down to 0 for months ongoing. And so once again, better level of care, better person-centered, person-centeredness for that organization. And once again, as we see here, a great reduction in the costs. So looking at this and just using this in a very targeted way, looking at this financially, you know, if you look in the state of Arkansas to stay in a human development center, we're looking at about $750 a day. And that was always everybody's, hey, we need a place for these folks to go. We need a place to send them. We were able to reframe this instead of saying, hey, how do you, not looking for places to send them, how do we work with you and your agency on being the place to go? How do we make it so you are able to maintain these folks? And we're going to come out and help you with that. So with this, if you just do the simple math, you know, if you have 5 individuals that are spending a month at a human development center, it's tremendous cost, $112,000 just in that month alone. And once again, these folks, once they get there, it's often very difficult to get them out. It's very lengthy. It's very costly. So even being targeted and making an impact there has tremendous value. Just being able to keep a few people out of institutional settings, the savings are very immediate. Okay. Additionally, if we look at, you know, the 100 people we serve, if you're able to just prevent a couple of those ER visits, let's say we can't get them down to 0. The goal is always 0, but if we're able to move the needle, every ER visit, every ambulance ride you keep, every day out of the hospital, the savings rack up very, very quickly. And with our targeted approach, our interventions reach thousands of consumers, because once again, we're not just working with the individuals, we're working with that system on the next people that come through their doors, as well as applying our strategies to existing clients that they're already serving. A great demonstration of this is just one of the success stories we worked with. We had an individual, this was a male in his 20s, and they brought Benchmark in. This was a foregone conclusion this individual was going to an institutional setting. They only wanted us in there to help maintain this individual's safety and the staff safety prior to that transition. So once again, the prior slide, the cost of serving this individual institutional setting, very expensive. And once again, we would argue not particularly person-centered. So when we went in, we saw, you know what, there's a lot of, this person has a lot of strengths. They have a lot of things that they do very well. Perhaps we can take a look at this program. We can look at salvaging it. With this provider, the way they had set up his program, the individual's program, he was no longer allowed to go to his day program. He was no longer allowed to use the telephone to contact anybody. He was not able to have any money to spend. He was actually not able to leave his apartment under any circumstances due to some of the safety concerns they had for him. And of course, as they made that individual's world smaller, we saw a tremendous influx in crisis behaviors and a lot of the things we talked about. So going in there, we were able to work with that individual, their team, and instead of making it smaller, we consulted with them. Hey, how do we put some systems in place to make this individual's life bigger, more community involvement, a higher quality of life? How do we work with that individual on being able to access the things that he used to do in a safe manner, and supporting the staff so they have the skills to manage it when things do go a little bit off the rails? And in doing that, we had really tremendous outcomes with this individual very, very quickly. So one, this individual, this was over a year ago, individual still has not gone to that institutional setting, which is very good. We were able to keep him in the community. We had an immediate decrease in behavioral incidents there. We decreased hospitalizations pretty substantially and prevented the costs associated with having to go into an acute setting. That individual, his person-centered care rose tremendously. He resumed his program, his day program. He was able to reunite with a significant other. He was able to access more of the community. And once again, as you increase person-centered supports within that agency, we saw a tremendous decrease in a lot of the crisis behaviors. And once again, that's what it's all about, not just for that individual, employing a strategy that now they're able to utilize for other individuals to have the same level of success. We saw an increase in medication fidelity, and even months after this individual's transitioned out, they've indicated he's doing great. So just using a targeted approach, a targeted intervention with our team, providing some immediate wraparound services, we're able to prevent that, alter that trajectory, and an individual that's, one, in the community enjoying a better level of person-centered care and a great deal of cost savings. Okay. I think there was a question regarding. So somebody had asked if Benchmark provides all the services and supports, or if we are partnering with the agencies. So one, we utilize a combination of both. We work to fill in the gaps that the state does not have available. Most of them could get a waivered provider in most cases, not all cases, but they don't necessarily have anyone to do a behavior assessment, to write a behavior plan, not just to write a behavior plan, but to come in and show the staff on how to execute that behavior plan, to provide that just little bit of additional crisis support. That is the difference between a person having to go into the emergency department or not, and then working to set up a system where we are able to fade out of that. So we generally did a combination and a hybrid of what was available within the state, as well as how we could fill the gaps that they either did not have access to, or just straight up were not available in the state of Arkansas as of yet. Okay, any other questions on any of our process there? I was just looking through some of the chat pieces. Did anyone have any other questions regarding our process and how that looked or how we utilize that? Somebody's asking about the slide presentation, Brian. Is that something we'll be sending out?
Yes. Yeah, we'll be emailing that to all the attendees.
Any other questions about our access model or anything we did in the state? Brian or Doug, anything we should have spoke to on this that we have not?
No, I appreciate you, everyone's attendance. And we would be glad to answer any questions you come up with later. It's something that we've done in a couple states and a couple different models. We did a very similar approach in Alabama, but working directly with the state with targeted providers that they identified as needing assistance. And it's a very adaptable model. So we're encouraged by the results we're seeing.
Mm-hmm.
Oh, is this, well, the question is this similar to the START model? And my answer is that we kind of, we developed this as an alternative to START because we believe that doing the large scale community training absent of the direct intervention approach educates a lot of people, but doesn't move the individuals being served forward very far. And so we thought that if you took some of the case management functions and training functions of START and combine it with a direct intervention and clinical intervention approach, we could really make some big impacts on people's lives and provider lives. And really the idea was to continue to lift the capacity of those providers so that they could serve the people that were struggling, and they would also be receptive to taking more people in who other people find very challenging. So it has some overlap with START, but I would say it's distinctly different. And the other thing with our model is that we have a zero reject model. Anyone who gets referred to us qualifies for the program. We don't screen people in and out. If we get asked to come in, we go. Charles, you want to take the question about how do you identify the most at risk?
Yes, and so this was a big question on this. The managed care organization and their care coordination team, they would refer the members that were coming through that they were constantly getting acute hospitalization referrals, referrals to go for additional hospitalization with the very high cost. We let the referral source be the managed care organization in terms of who was giving them in the state the biggest pressure points. Now, the managed care organizations, they're getting that from the providers. We have this individual, we might not be able to serve them. That would filter through the managed care organization. They would try natural supports and, hey, we need some additional support to work with this person, or this provider needs some training and support on how to support members like this. So we allow that referral source to come from the managed care organizations, which allows us to really have a great thumb on the pulse of the individuals that need the most support. Back to, I did just want to indicate Doug had talked about the differentiation. Our providers in the state indicated one of the START was in Arkansas, and they'd indicated one of the big differences with us is we show up. We don't just talk about things. We don't do classroom trainings. We do those pieces, but we actually are present. We work with the individuals. We provide that level of direct service that really differentiated us from that model, particularly in the state of Arkansas.
And there's another question about recruiting of BCBAs. Our BCBAs are employed. We try to recruit locally. Charles, how did we get you to Arkansas?
So they had hired, you guys might have heard it in my long O. I'm actually from North Dakota, Minnesota area. They were able to recruit me down. But then our other some of our other BCBAs that we've had, we have been able to recruit locally as well. So that has been a tremendous help to have people that are in the state that have a good idea of that, as well as getting some outside perspective. It's actually been a wonderful balance of having that local individual that knows the state and how things work there, as well as getting some outside perspective. So for our team, it's really been a great blend of both of those worlds.
There are just a couple quick comments I want to make and highlight. When Charles talked about referrals coming from the managed care organization, that care coordination team, one of the things that we pride ourselves on is making sure the fact that we're communicating back to the MCO in regards to what we've done as far as assessment, what our treatment plan is, what our engagement strategies are with the individual and the provider, and what our treatment plan is. So they receive generally weekly updates in regards to what we are doing. So there's no surprise or unexpected occurrence with the individual, with the provider agency that we're working with out in the community. So and we want to ensure that we work very closely in lockstep with the MCO in regards to how we're working with these high service utilizer individuals. The other piece is the work, I think, really based off the work that we've done in Arkansas and in Alabama that Doug alluded to, is that the amount of improvement or increased capacity that the provider agencies have experienced and their willingness now maybe serve individuals historically that they have not, that they would have issued a do not serve notices. Now they're willing to take and serve those individuals, knowing that they have support from Benchmark, and they're willing to increase their capacity and serve more individuals. And the reason I bring that up is that's one of their common refrains that we hear, especially from MCOs and other payers, is that the providers are struggling either to secure staff, maintain staff, and they don't have the capacity or the skill set to serve these high need individuals. And that's where I think we come in and serve a great need, supporting the provider and the staff so that they can do the work that they need to do and also ultimately increase their capacity to serve more difficult people. And again, as Charles said, the fact that becomes a long-term benefit gain for the provider and ultimately for the MCO.
We just had an individual was briefly incarcerated due to some significant behavioral issues, and they had reached out to every provider in the state and gotten a rejection. One of our partner providers we had worked with, we were able to make a call and we were able to problem solve with them and with the managed care organization, with their care coordination team. That person is actually just moving in today to a community setting who was previously incarcerated with literally no other place to go. So that's just, and once again, developing that relationship, working with that organization and how to support an individual like that was a direct result of this model. Any other questions?
Okay, you still have time. Any other questions, folks? Okay. All right, if it's okay with you guys, I'll close this out. Any last thoughts?
No, I'm glad to see Arizona is going to be reaching out to us.
Excellent. Well, I can't say enough about your presentation and the great work you're doing with our members, but most importantly, their Medicaid enrollees. This was an excellent presentation. I'd like to get the slides too, if you don't mind. And folks, you saw the contact information. You can reach out directly if you have more questions. If you prefer to do it that way, you can reach out to MHPA. We will connect you with the Benchmark team and their excellent expertise. You can also meet them at MHPA 23 this October 18th to 20th at the Gaylord National right outside DC. We hope to see you there. And again, Benchmark will be there, so that's an excellent time to chat with them and get more of their expertise. And with that, I want to thank our presenters. Again, excellent presentation. You're doing great work. It's awesome to see. And I think the questions, bear that out. You've got awesome questions. So with that, everyone, thank you for coming and have a great afternoon.
Great. Thank you very much.
Thank you, everyone.
Everybody.
Bye.